this is Jennifer Feruzes, and I am going to be talking about caring for the woman during the postpartum period. This is also called the puerperium period. Technically, it's the first 6 weeks after delivery. In the hospital, of course, you're only going to see them for 2 or 3 days after they deliver, but all of your education towards the patient has to deal with this first 6 weeks. So what you are assessing with your patient is their reproductive system and the uterus and all the reproductive organs returning back to the non-pregnant state. This is called involution. Involution is where the fundus of the uterus decreases by 1 centimeter every day until it can no longer be palpated, which is around the 10th day. There's lots of different things that affect involution, and it's the ability of the uterus to contract down. So probably the biggest thing is the overdistension of the uterus. So you see this in babies that are very large, like 9-10 pounds, with multiple gestations, like twins and triplets. Those things are going to make the uterus get very large, and then it's not going to want to contract down. It's more difficult for the uterus to contract down. Certain medications are going to promote uterine contraction. Probably the biggest one that we see is oxytocin or Pitocin. We routinely give a lot of Pitocin during labor to at least augment it, but I would say that the majority of women all receive Pitocin immediately after delivery of the placenta. And this is to prevent a postpartum hemorrhage and to start that involution process. Breastfeeding is another thing that helps the uterus to contract down. When the baby nurses, that stimulates the pituitary gland to release normal oxytocin, and that besides helping the milk to come down, it also helps the uterus to contract. Another big thing that we're assessing on the woman is her lochia, the amount of bleeding that she's having. And the lochia has different words to describe what it looks like and when it occurs. So the 3 types are rubra, serosa, and alba. So rubra is red in color and lasts for about the first 3 days. Serosa is a pinkish color, and it lasts up from about day 3 to day 11. And alba, which is a white in color, starts after the serosa and lasts for 3 to 6 weeks. Now, besides the type of lochia, you're going to look at the quantity of lochia. So what you should expect that immediately after birth, there's going to be what you would look at and think is a large amount of bleeding, probably filling a pad within an hour easily. And then every hour and then every day, it gets less and less and less. Another thing that we're going to be looking at is the breasts. So you're going to palpate the breast, ask the mother, how do the breasts feel? Do they feel like they're starting to fill with milk? The estrogen and progesterone in the body is going down after the pregnancy, and you're starting to see increased production of prolactin and oxytocin. So prolactin is involved in milk production, and oxytocin is involved in the letdown reflex. So right behind the nipple are little collection ducts that store a small amount of milk. Then there's little ducts that go beyond those collecting areas where all the milk is stored. So when the baby starts nursing, it gets first that beginning milk in the collecting ducts right behind the nipple, and then after approximately 1 to 2 minutes, all the rest of the milk that's stored behind there lets down. Another thing that we're checking for during this time is breast engorgement, where the breast may be rock hard, extending all the way to the end of the nipple. That makes it very difficult for the baby to latch on. Remember that colostrum is what's produced in the first few days of life. This is a dense, yellowish, thicker type of milk coming from the breast, and it's rich in protein and immunoglobulins, and is very important and very good for the baby to receive this. So this picture is just demonstrating the relationship between the production and the letdown of the milk. The baby sucks on the nipple. This triggers a impulse for the pituitary gland to release oxytocin, and that causes the muscles around the alveoli to contract and release the milk down through the nipple. So milk production is all based on supply and demand. The more the baby wants to nurse, the longer the baby that nurses at each feeding, the more milk that's going to be produced. It's a very simple concept. It's one that you need to stress to the mothers, because what happens is mothers say, I don't have enough milk, my baby's not getting enough to eat, and then when you question her, you realize that she's only nursing every 4 hours. All right? So what you want to tell her to do is to nurse more often, like every 2 hours, and that will help in producing more milk. Cardiovascular wise, we look at the amount of blood loss. That's very important because we're wanting to monitor for postpartum hemorrhage. In a normal vaginal delivery, you lose about 500. In a cesarean, you lose about 1,000. Right after birth, the body's trying to get rid of all the extra fluid that's in the woman's body, and that extra fluid is returning to the venous system. That increases cardiac output for the first few days. Meanwhile, the body's trying to get rid of all that excess fluid and does that through diuresis and diaphoresis. The GI system is affected in the sense that after delivery, most women are very hungry and very thirsty. This is partly due to the fact that we've been restricting food and fluids, but also because she's been working very hard and very long, and her body is giving her signals that she needs more food for energy. Women also might complain of constipation at this time. Okay, all the skin changes that happened in the woman are starting to fade. It doesn't happen overnight. It takes a while for them to improve. The women might have problems with either incontinence or not being able to urinate. And so you're going to manage those, either by catheterizing the patient or helping her to get up to the bathroom so that she can empty her bladder on a regular basis, like every 2 hours. She might complain of extreme diuresis and that she is sweating profusely. Musculoskeletal wise, the body's trying to go back to its pre-pregnant state. The relaxin in the body is decreasing, so a lot of the ligaments that were stretched are now returning to the pre-pregnant state. Neurologically, she might be in pain, she might be fatigued. You're going to be assessing her ability to move her legs after the epidural, and you are looking out for signs of PIH, like visual disturbances, because sometimes PIH doesn't present itself until the 4th trimester. Okay, endocrine-wise, well, we already talked about breast milk production. Menstruation usually reoccurs in 2 or 3 months if the woman is not breastfeeding. If the woman is breastfeeding, then it depends on how frequent she's feeding. For instance, if she is feeding every 2 to 3 hours around the clock, she will probably not get a period until she reduces that frequency. So maybe she'll go down to maybe every 4 hours around the clock, and then she'll go to every 4 hours only during the daytime, and then she'll go down to maybe 2 or 3 times during the day. So as she nurses less and less, the endocrine system starts functioning better, and she will eventually start getting a period. But that doesn't mean that she can't get pregnant, because we don't know exactly when the hormones kick back in and she starts ovulating. Weight loss wise, most women lose about 12 pounds immediately after the delivery, and that's the baby weight, the placental weight, some extra fluids coming off of the body, the amniotic fluid. Then in the first few weeks, women lose about 8 pounds, but most women don't lose all the weight that they gain until 6 or 12 months after they deliver. So on your postpartum assessment, you're going to go in, you'll have the vital signs for you. You want to start, from head to toe. So I usually start with the breasts. I'm looking at the nipples. I'm looking at the breasts themselves, if they're becoming engorged. I'm listening to the lungs, make sure that she isn't having any complications. Checking the fundal height and the quality and consistency of the fundus. Actually looking at the lochia, not just talking to her about it, seeing what type it is and how much. Assessing for bladder distension. I always turn the patient on their side and look at their bottom if they had a vaginal delivery. I'm looking for the repair of the lacerations. I'm looking for any redness, edema, ecchymosis, any discharge, and how well approximated it is. At that time, also, I look to see if she has any hemorrhoids. If the woman didn't have a vaginal delivery, then you're looking at the C-section incision. Make sure that it's not red, there's no drainage, that it's well approximated. And you want to look at the lower extremities. Make sure that that the Hohmann sign is negative, and that the deep tendon reflexes are about 2 to 3 plus. And if it's immediately after the epidural, after delivery, you're going to be checking for her ability to move and sensations in her legs. In the first 24 hours, it's real important to measure the intake and the output and make sure that the lady's voiding, so you're monitoring that. And you are also monitoring and treating her pain. Also, watch how she gets up. How does she move? Does she seem stable? Is she in a lot of pain when she's walking? You want to stay on top of the pain, and lots of times we keep pain management, pain medication on a regular basis while they're in the hospital. So you might medicate the patient, for instance, every 6 hours. Just a little bit more about breastfeeding. It usually takes about 2 weeks for the whole breastfeeding process to mature. And in the beginning, it's mom's learning, baby's learning. There's a learning curve there, and it might take a while for both the mother and the baby to catch on how to do it. So we all know that the first phase of milk production is colostrum. It's high in protein, vitamins, minerals, and especially immunoglobulins. Then we go to this transitional milk for about 4 to 10 days that has more calories in it and starts to have some lactose and fat in it. And then after about 2 weeks, we have the mature milk. Also, at each feeding, you have to look at that the milk actually changes during the feeding. So in the beginning, you have the foremilk, which is that milk that's right behind the nipple, right? This is sort of like, think of this as like the appetizer for the baby, right? It helps to quench the baby's thirst and contains lactose and proteins, but not as much fat and calories as the hind milk has. So the foremilk is actually a small amount, and then the hind milk is a larger amount. This is one of the reasons why you want to make sure that the woman, when she breasts, that she empties one whole breast before going onto the other side, so that you get all that hind milk. That will give the baby the fat and calories that they need. And then hopefully, completely empty the second breast. Some other advantages I always want to stress with women to promote breastfeeding. It's much easier for the baby to digest the milk. They have less tummy problems, less problems with diarrhea or constipation. Colostrum has like a natural not only colostrum, but all the breast milk has a natural laxative in it. So babies are less likely to become constipated. And in fact, babies might have a poopy diaper every time you change it, and that's normal. Breast milk also has the correct amount of nutrients and calories that your baby needs. It's got the immunoglobulins in it. You don't have to buy the formula. You don't have to make the formula. If it's readily available, if you're available there, and it also promotes bonding between the mom and the baby. Okay, um, let's change directions here a little bit and talk about the psychosocial adaptation. So immediately after the birth, and probably for the first 24 hours or so, the woman is just sort of taking in the whole experience. And during this time, you're going to see that she's very focused on herself. She even needs help taking care of herself. You know, needs help with changing her peri pad, or needs help in walking to the bathroom, and she needs people to get her food for her, and she just wants to sort of be taken care of. Also at this time, she is taking in the whole experience. You know, when did she come in? When was she fully dilated? She, what, how did she feel about pushing the baby? How did she feel when she first saw the baby? And she keeps talking about this experience and sort of cementing it into her memory and making it real by talking to people and retelling the story over and over. And that's very normal. After about the first 24 hours, women start to take hold, starting to take care of themselves, and also are starting to show interest, more interest in the baby. In the taking in period, the nurse might come in, change the baby's diaper, and then hand mom the baby so that the mom can breastfeed. During the taking hold phase, mom's going to get out of bed, she's going to change the baby, and then she's going to take the baby and nurse the baby. All right. During the letting go phase, which might start to occur about the same time as the taking hold or a little bit after, they start letting go about some of their ideas about what they thought the delivery was like. For instance, this past week we had a woman who had a failed home delivery, and so she ended up coming into the hospital and having her baby in the hospital with an epidural and all that. And she was really sad that the way she envisioned her delivery being didn't occur. And she hadn't reached that letting go phase. And I was telling the students, oh, it'd be sort of nice to talk to her in about 2 or 3 days to see if she let go of that and was able to see the beautiful experience that she did have with the birth of her baby. Other things that people might have to let go of besides their birth plan is maybe the sex of the baby or what the baby might look like. Um, Sometimes babies are born with birth defects, and so they have to let go of the thought that their baby isn't perfect. Um, so there might be certain things that they have to let go of. Other things that might be down the line is letting go of their previous lifestyle, the freedom and independence that they have, and now that they have to be available and take care of their child 24/7. Okay, let's talk a little bit about postpartum complications. Um, this is a complication that has to deal with placental adherence to the uterine lining. And what happens is that the placenta, instead of just barely being attached to the endometrium, what happens is it starts growing into the endometrium and then into the myometrium. So if you look at the slide on the left, you see that the accreta, which is the least invasive and the most common type, goes through the endometrium and starts embedding itself into the myometrium. The increta goes even further into that, and the percreta goes even out of the myometrium. So look at these slides and you can see that. The problem with this is that it buries itself so much into that uterine tissue that it can't let go. And so what happens is, as the doctor tries to pull and get the placenta to deliver, it doesn't. All right. Now, on the accreta, sometimes they can do those. They can, tug on it and it can come out. But on the increta and the percreta, it's very difficult. And what ends up happening is they end up taking the woman back to the OR, and the woman gets a hysterectomy. These are not really real common. Another thing that could happen is you can have a uterine inversion. That's why when we check the uterus, we put one hand above the symphysis pubis. You see a uterine inversion sometimes when the doctor is pulling too strongly on the cord, and it just inverts the uterus out of the body. So what happens there is that the physician has to put the uterus back into it, as you can see being done in these 3 slides. Hopefully she's got an epidural in place for this, because this is very painful. Probably what you're going to see more of is postpartum hemorrhage, and you're most likely going to see the early hemorrhage. Early hemorrhages occur in the first 24 hours, and they're usually due to uterine atony or trauma. About 99% of hemorrhages are due to uterine atony or trauma. Late hemorrhage occurs after 24 weeks and up to 6 weeks, and this is usually due to retained placental parts. So when the placenta breaks loose from the uterine lining, it should come out in one piece. Sometimes it doesn't do that. It comes off in pieces, or the doctor might want to pull on it before it's ready to come off, and so therefore some of the pieces stay still attached. And if the placental fragments are still in there, then when the uterus starts contracting, it won't contract. And it might be such a small little piece that it doesn't get caught, it doesn't get detected in the early period of the postpartum period. Right, so it just stays there, and the woman just has a little bit of a trickle for a much longer period of time, and then those women have to come back into the hospital and have a D&C. Okay, so the signs and symptoms of a postpartum hemorrhage are, well, obviously bleeding, a decrease in blood pressure, the woman looks pale, she may have a decreased level of consciousness, and usually the cause of a postpartum hemorrhage is because the uterus is not contracting like it should. It's been overdistended, like we talked about earlier. Maybe she had too aggressive use of a Pitocin during labor, and now the uterus is just too tired to continue to contract. So the nursing care about this, first of all, is to monitor the patient very closely. That's why we take her vital signs every 15 minutes for an hour, and check the bleeding and check the fundal height, and also the consistency of the fundus. So we try and get rid of any excess blood that might be accumulating in the uterus. So if you look at the top picture here, you can see that there's some blood just sitting in the uterus. That happens when the uterus doesn't contract down. So what the nurse is going to do is she's going to press on the fundus to try and push out that blood. And lots of times just pushing out that blood and any clots that might be in it is enough to help the uterus to contract properly. What you see in the bottom picture here, this is the nurse doesn't do this. The physician comes in here, and you can see that the physician is putting his entire fist into the vagina, and then the top hand is on the fundus. So basically what they're doing is they're squeezing and holding pressure. Think about like if you had, let's say that you have bleeding from somewhere on your skin, and you wanted to stop it from bleeding, you would put pressure on it. So that's what's being done here. And the physician might keep her hand in there and on top for maybe 5 minutes to try and decrease the amount of bleeding that's occurring. As a nurse, you want to estimate your patient's blood loss as good as you can. So we had a postpartum hemorrhage, I remember, from last semester, and the lady was bleeding excessively. And what they do at Hoag is you have the chucks underneath her, you have the peri-pads, so they know how much the chucks and the peri-pads weigh. They bring a baby scale into the room and they start weighing everything so that they can have an actual count of the amount of milliliters of blood that the patient is losing. So when you're taking care of these women, well, we're going to give Pitocin, we give Methergin, we can give Hemabate, Cytotec. All those things are going to help the uterus to contract, right? So the important thing is for the nurse to recognize that the lady's hemorrhaging and to get these medications on board as soon as possible. Okay, we want to prevent thrombophlebitis that can happen when a woman's legs are in the stirrups for too long. So what you're going to see when a woman is in stirrups, that in between pushing, they'll either bring her legs out of the stirrups or they'll let her legs rest. And that's really important also because a woman gets really tired of holding her legs up. So be really cognizant of how long the woman is in the stirrups. Puerperal infections are infections that occur in the postpartum period. The main things that we're looking at here are infections in the uterus itself, wound infections from C-section sites, UTIs, from multiple catheterizations and incomplete emptying of the bladder, mastitis, which is a breast infection, and also septic pelvic thrombophlebitis. One way that we look at infections is to look at the woman's temperature, and we have very clear-cut guidelines here. So if a woman has a temperature of 100.4 on 2 of the first 10 postpartum days, after the first 24 hours, the nurse should have a very high risk of suspicion that this woman has a puerperal infection. And you're going to see that there's a lot of prophylactic antibiotics given for women who have C-sections, or women where there's a lot of instrumentation during the delivery. So endometritis might occur from multiple vaginal exams, especially when the membranes are ruptured, fetal scalp electrodes, IUPCs, vacuums, forceps. Anything that you put into the uterus might bring germs along with it. Mastitis is an infection in the breast. It's usually associated with an incomplete emptying of the breast milk from one of the lobules, and you can see all the different lobules here. Usually happens in one breast on one area, but it can spread to other areas. It's painful, it's warm to the touch, it's red, the woman has a fever, she has flu-like symptoms, and she can become very, very sick very, very quickly. So that's one of the things you want to educate her about, preventing mastitis by completely emptying both breasts at each feeding, rotating which breast the baby starts on, using different positions so that you empty all the different lobes of the breast tissue, and that if she were to have a fever or any redness or localized areas of pain, that she should call her healthcare provider. So, nurses' main role in the postpartum period is to assess for normal uterine involution and to help the woman to understand what her body's going to be going through for the next 6 weeks, to educate her about taking care of her baby, to help and to educate her about breastfeeding. It's an important role, and I hope you all learn and teach your patients a lot.